I first want to thank the organizers to offer me the opportunity to present on some of the hot topics related to cystic fibrosis related diabetes, meaning how can we diagnose and why do we diagnose cystic fibrosis related diabetes. I was helped in the preparation of that presentation by Catherine Porter, which is one of the research assistants of our group. I want to disclose my commercial relationship and grant relationship. I do have relationship with companies that could have interest in that talk. For example, some companies in the field of cystic fibrosis like Vertex, and probably more important, all the companies that do have commercial continuous glucose monitoring systems like Abbott, Dexcom, and Medtronic. So CFRD has really emerged in the last 20, 50 years as a major complication of cystic fibrosis. Now, north of the border in Canada, the median life expectancy is 51 years, and it has been a very rapid rise of that life expectancy. But as the main factor to develop cystic fibrosis-related diabetes is age. So by 50 years of age, approximately half of the adult patient will have already cystic fibrosis-related diabetes, and an additional half will have some form of pre-diabetes. There is a very strong association, and I insist on the word association. We haven't proven yet, though there is big argument for a causal relationship. So there is an association between CFRD diagnosis and lower BMI and lower FEV1, which usually translate by an increased risk of early mortality in people with cystic fibrosis-related diabetes. So the current and validated goals to screen for cystic fibrosis-related diabetes is really to diagnose those people as early enough. So you want to prevent the acute complication, those patients that used to come in past years with very high blood glucose, dehydrated, for example. You also want in people that have a reasonable life expectancy to prevent some diabetic specific complication like eye or kidney complication that would clearly add on the burden of those patients. However, because of the very close relationship, and once again, association, no proven causal relationship, though it's probable, because of the association with lower BMI, lower FEV1, and earlier mortality, you could imagine that screening for cystic fibrosis-related diabetes could be extremely interesting to identify the patient that could be at higher risk to lose weight or lung function, because those two curves are quite parallel, the curves of rising glucose and the curves of having the BMI, the weight, and the lung function going down. So you have roughly three big accepted methods to screen for diabetes. There is fasting blood glucose. I will come back on some limitation. The big recommended test is oral glucose tolerance test. It's the way to diagnose diabetes, any kind of diabetes, and for example, the most frequent one, type 2 diabetes, it's accepted. And there are also, because hospitalization is usually a time at which blood glucose would rise quite rapidly, measurement of blood glucose within the first 2 days of hospitalizations, for example, for an exacerbations. And then you have all those categories of glucose. The most important category is normal glucose tolerance. Then you have at the bottom, you have cystic fibrosis related diabetes, but you have a lot of intermediate dysglycemia categories. And for our US colleagues, the equivalence in milligrams per deciliter is at the bottom of the slide. Here, it's international units. So you have that complete spectrum between normal glucose tolerance and cystic fibrosis related diabetes with a lot of categories in between. Those categories are used also for type 2 diabetes. However, the one highlighted in red is cystic fibrosis specific, meaning that people that have a peak of glucose at 1 hour of an oral glucose tolerance test probably have some CF specific problems. At least we identified with these people with lower FEV1 and in some studies, lower BMI. So what are the current challenges with the current test that we have? One problem do we have is who to screen. The clear recommendation is all patients, But one wonder if we could target some patients, at least in the adult world. I will very rarely allude to the pediatric world in that presentation, but when you're 30 years of age, you have not developed diabetes, maybe you should not be eligible for yearly testing as recommended in the recommendation. It could be conceived. When to screen? The recommendation is annually in all patients, but as I will allude later in the presentation, this creates a lot of burden both on the patient and on the healthcare teams. How to screen? This will be the core of the presentation. I already alluded to fasting blood glucose, oral glucose tolerance test. There's a biomarker A1C, also called HbA1c, which is glucose on red blood cell, which give a good indication of the last 3 months glucose. And there are emerging technologies like continuous glucose monitoring, which are small devices that allow to be worn for a few days and that collect data on a regular basis. So one would have a more simple method than oral glucose tolerance test, and ideally reduce time and cost and improving compliance. Most big centers in North America that have published their numbers are just above 50% of the recommended number of OGTT in the adult world. It's usually a bit better in the pediatric world. And now the threshold that are used to diagnose diabetes, for example, fasting blood glucose above 140 milligrams per deciliter, are the threshold established for the risk of retinopathy in type 2 diabetes. We wish that we could have things that would be more pertinent for weight, for lung function, and ideally to predict the patient at higher risk to do this, and also maybe have threshold that would predict that the patient is at high risk for CFRD. So this is a key figures from the one of the last consensus, and you can see that for different kind of patients, if you're pregnant or if you're a healthy outpatient, if you're hospitalized or if you have continuous drip, there's different methods and different thresholds. That might be quite easy for someone like me working in diabetes. That might not be very easy in some CFRD teams. This is evidence-based, but I understand this can create some confusions. So let's revise all those criteria and see which one could be useful or not. This is unpublished data, and others have already shown this. It's from our team. We have a large cohort in Montreal with about 300 patients, and we just looked if the fasting versus the 2-hour glucose after no GTT, which on those things we were diagnosing people. And what you have in red is what have been captured by 2-hour glucose measured during a no GTT. Though obviously fasting blood glucose can happen to diagnose diabetes, but is far less frequent than 2-hour blood glucose. So oral glucose tolerance test is the recommended test, and it's clearly a recommended test. I would advise that all patients have, but in that presentation, I will also allude to the limitation of that test. It is clearly time consuming. You need 2 hours, you need a nurse, you need blood samples, you need glucose, which is standardized. So it doesn't use a lot of cost. There is very negative perception, good papers on healthcare teams, excellent papers on patient, they just hate it. So the net result is a very low adherence rate. As already alluded, in the adult world, it is usually a bit above 50% in good centers. Good centers, EI centers, putting a lot of energy on this. Not only this, when you look to reproducibility and variability of OGTTs, so you have a patient doing the same test on the Monday, on the Wednesday, on the Friday, you are going to have huge variability from test to test. This is well demonstrated in general population in type 2 diabetes. I'm not aware of data in CF population, but I don't see any reason why it should not apply here. And then you have all those pre-diabetes categories in that impaired glucose tolerance. Do we treat them? Do we monitor them differently? There is no good evidence data for this specifically related to cystic fibrosis patients. And finally, as I already alluded, the cutoff we use for diagnosis are the ones for the risk of retinopathy, so eye damage in people of the general population. It is not the one that we wish, and maybe those cutoff could be different for the BMI, weight loss, or lung function loss. So we do have additional challenges. Going back again to the big cohort we have in Montreal, actually, if we classify people from NGT, normal glucose tolerance, to CFRD, cystic fibrosis related diabetes, but that we add a very simple additional character, which is pancreatic insufficiency or pancreatic sufficiency, which is rare, but still can happen in cystic fibrosis related diabetes. We can see that we can more clearly relate the BMI and FEV, two key factors in CF management, to pancreatic sufficiency versus insufficiency, rather than diabetes versus no diabetes. So an ideal test could be hemoglobin A1C, A1C or HbA1c, which is that biomarker red blood cell, the sugar that's on red blood cells, that is a biomarker of the last 3 months of glucose control. The problem is that A1C tend to underestimate glycemic control. There's a huge controversy on is this huge or important or mildly important. Still in CF, there's a consensus that it underestimates. So the net result is that you can have a perfectly abnormal OGTT with a perfectly normal HbA1c. However, recent teams, and specifically the Toronto team, have proposed to tell that below a certain threshold, which would be around 5.5, 5.6 A1c, probably you don't need to do an OGTT, because the likelihood that the OGTT would be pathologic, like CFRD, a new diabetes, is very, very low. And there is a lot of hype around those new devices, continuous glucose monitoring. We use them as endocrinologists tremendously in people living with type 1 diabetes, and more in people living with type 2 diabetes. At least in the insulin-treated field, it's now nearly standard of care when we can have access to it. They don't measure blood glucose. They measure glucose in the interstitial fluid, and this is always a bit late as compared to a blood glucose, let's say 10 to 15 minutes. So it's a good surrogate. And why is it an advantage? Because you can measure those blood glucose not only for a long time, you can see here 10 to 14 days in most devices, but the machine is going to sample the blood, the interstitial glucose, each 5 to 15 minutes. So at the end of the day, you're going to have between approximately 100 and approximately 300 values per day. The data is either you need to scan the little coin size you have on your body, or it goes directly to a phone app, and the patient is in usual life data. You know, OGTT, which I already presented, it's a huge load of glucose, and though some CF patient could use this in some cases, it's not really physiologic. Here, it's going to be their real life. So what happened is at the end of it, you have those graphs. Each color here represent a day, and you have the blood glucose on the vertical axis, and you have a full day on the horizontal axis, and you have repeated days here. So you can see in the blue circles on the top that this patient clearly had some excursion above what is considered as a threshold. Still, this patient had an A1C at 5.1%. This patient has a perfectly normal glucose tolerance at the OGTT. So if you do continuous glucose monitoring in a patient, you likely find some abnormal glucose values, and you could label everyone as sick, which has not been yet proven. We have quite a lot of cross-sectional studies with continuous glucose monitoring. We are still lacking good, large, prospective studies to see if those values really have an importance for the patient, or are we going to treat or to monitor, to impose on the patient some dietary or glucose monitoring measures that might be useless. So to summarize all of this, 2-hour glucose tolerance test is clearly the recommended test. It is more sensitive. It has a lot of advantages as compared to the fasting blood glucose, which is simple, but we'll see on the next slide, no sensitive. It's same for A1C, and continuous glucose monitoring systems at the bottom. We're still missing good data on large cohorts. Now, the disadvantages, as I said, 2-hour glucose tolerance test, it's the recommended test, but there is a low adherence by the patient and some healthcare teams. It's a significant burden. There is high variability in results. But if you look to other categories of tests, there are also some problems related to each test. So there's not one test emerging as a good alternative to the currently recommended 2-hour oral glucose tolerance test. So what are the novel approaches here? And here I'm going to skate on the thin ice because some of them are not fully validated, but for all of them, we do have some data. So one alternative is fructosamine. Fructosamine is a protein which also binds with glucose. And because red blood cell turnover is not perfectly normal, probably in some CF patient, this could bypass that red blood cell turnover things. There is a good paper by a Canadian team showing a reasonable thing. It needs to be confirmed in other hands and in larger studies. And then you have continuous glucose monitoring, a lot of data available. And what happened is that you can see here that when you classify patients on the horizontal axis based on their OGTT data, you can see from various measurements of the continuous glucose monitoring, for example, on the left, the mean that you can differentiate people that are normal glucose tolerance, from the one that have cystic fibrosis related diabetes. And then you could also see different things for OGTT and HbA1c data. Here, HbA1c, that biomarker of 3-month glucose control, is on the horizontal axis, and you have on the vertical axis fasting blood glucose. You see the correlation is not so good, but when you move to the right-hand side, you can see with the 2-hour glucose tolerance test, you have a better correlation. So A1C could capture some part of the oral glucose tolerance test. Probably more interesting for cystic fibrosis related people that are living in the CF world, you can see here that HbA1c on the horizontal axis and now on the vertical, key factors for CF management, BMI on the extreme left and FEV on the extreme right, you can see there are some correlations. So you could imagine that HbA1c could capture some of the data of OGTT and that you could use it to have less OGTT done. Finally, can we see who is at risk? We know that some genotypes clearly increase the risk, that a patient that is pancreatic insufficient clearly have a high risk, that situation that leads to insulin resistance like exacerbation clearly increase the risk. Emerging a few recent papers, we do have now patients with CF that are obese and this increase the risk. Also, patients that have a family history of type 2 diabetes are also at high risk of earlier CFRD. Patients that need steroid medications after lung transplant. I'm nearly not aware of people that have not developed diabetes, and each time there is an acute illness. Now, you could see patients based on the test that we have that could be at low risk. For example, people that have repeated on a yearly basis normal OGTT, maybe we could space them a bit. Not proven, I'm just suggesting that this might be. Conversely, people that have high blood glucose at the fasting level on a test done for something else, people that have, when it's available, low insulin secretion, people that have, where you capture some postprandial hyperglycemia, some people that have various pre-diabetes categories could be at high risk. So here is the idea we are coming from. This is not validated, is that maybe at least in adults, we could have initial detailed screening, then we could repeat this and have A1C on a regular basis, and then come to an algorithm which main goal would be to reduce the number of required OGTT in adult patients. And you could have patients that could be based on low risk. For example, they're already 45 years of age, they had regular OGTT that were normal, and maybe we could space this a bit while still making A1C to see if they are at, the risk evolve. And then you could have people at high risk where you could have OGTT at least on a yearly level. And we need to figure in this the place of continuous glucose monitoring, which is an emerging technology. So to summarize, CFRD is clearly a big complication of CF, and it's associated with major complication, including early mortality. The screening goal is clearly to diagnose CFRD, but we wish that we could, with that test, also identify people at high risk to develop in the next years decline of BMI or FEV1 larger than what could be predicted from their clinical history. OGTT is clearly the gold standard and recommended test, but it comes with a lot of problems. So we are looking to have other tests. It's probably possible to reduce the number of OGTTs in adults, either to use A1C as a first step and then don't do a GTT if the A1C is really low, or to develop some algorithm with higher and lower risk patients. And clearly continuous glucose monitoring, there's a lot of hype around it. We're still missing some good evidence data, and nothing that I've said is alluding to pediatric patients. I thank you for your attention. Merci beaucoup.
Welcome to this meeting. This is lessons from continuous glucose monitoring in youth with cystic fibrosis, and I'm Shihab Hamid, pediatric endocrinologist. These are my disclosures relating to the CFID trial. I'd like to start by taking on a virtual trip to Australia. In the coloured map on the left, you can see the Indigenous nations of Australia, the Eora people, custodians of the area where Sydney Children's Hospital is located near Coogee Beach. I often commute there across the harbour, and here's the harbour bridge and opera house. The other day there was a terrible accident with a car veering across one of the narrow lanes, and it got me thinking about glucose homeostasis. Normally, insulin secretion by the 1 to 2 billion beta cells that we have is tightly coupled to portal circulation glucose, and by that means we're able to keep glucose levels tightly controlled. With diabetes, we have to manage to do that artificially with insulin therapy, and it's very easy to get that wrong, causing hypoglycemia. In neonates, when glucose levels get under 2.6 millimoles per litre, there are EEG changes appreciable, and those can result in neurocognitive impairment. And in worst case scenario, severe hypoglycemia can be fatal. On the other hand, humans are usually able to keep their blood glucose levels under 8.3 millimoles per litre. But when they get above that sort of number, then glucose is detectable in airway secretions, and in CF that may contribute to lung function and nutritional decline, and also eventually hyperglycemia can cause microvascular complications. So it's important to keep your eyes on the road. Urinalysis is analogous to driving along blindfolded and being told where you were a few hours ago. Finger stick testing is being allowed to open your eyes a few times a day, and continuous glucose monitoring in this analogy is being able to see where you are every 5 minutes or so, and also whether you're veering to hyper or hypoglycemia, and also where you've been, say perhaps for instance overnight. And it generates an enormous amount of data, but can they be trusted, and how should they be acted upon? Well, there's been tremendous improvement over the years, not least in wearability. The devices are now wireless, smaller, they've got improved insertion methods, and some of them require no fingerstick calibrations at all. They transmit in real time to smart devices, and there are web-based platforms that allow you to look at all the retrospective data and make adjustments. Many people will eventually be on closed loop pump systems where the pump and continuous glucose monitor talk to themselves and take the thinking out of diabetes. Well, that's the goal. All the sensors work by measuring glucose in the interstitium up to 288 times a day using glucose oxidase as the method. And it's important to realize that this lags behind changes in plasma glucose. So when you study that using radio-labeled glucose given as boluses into the intravenous fluid, the glucose level will take about 5 or 6 minutes to be detected in the interstitial fluid as compared to the plasma. And in real life, looking at various brands of CGM devices, that also plays out. And that lag seems to be worse, at least in this study, in adults, and increases with age compared to adolescents. And it may be due to thickening of the skin. And looking at how that plays out, say for instance, if you're going to exercise and then eat, that can make an important clinical difference. So here in the black circles are plasma glucose levels falling and then rising post-meal, and in the wide open circles, significant lag before those events happen on CGM. So how do you know, apart from the lag, whether or not you can trust your CGM results? There's a variety of different CGM terminology looking at sensor accuracy, and one of them's the MARD, mean absolute relative difference, not a sulky mood or fit of petulant bad temper. It's looking at the absolute error, the average of the absolute error between all the CGM values and matched reference values. So usually the reference values come from a YSI machine which measures glucose values accurately, but sometimes just from finger prick capillary glucometer values. There's also mean relative difference, which looks at whether things are systematically under or overreading. And there's Clark's error grid analysis, which looks at the clinical importance of a discrepancy between two types of measures. So here are the different zones mapped out showing differences between sensor glucose values and capillary glucose with corresponding values in A zone, but large discrepancies out here in the peripheries, like in zone D, where you've got a high capillary glucose value reading as a low sensor glucose value, and vice versa in E. And here's data from the Freestyle Libre machine compared to capillary glucose, with most results in that A or B area and few results out in the extremes. Apart from the published data that each sensor reports, it's also useful to look at head-to-head studies where CGM devices are compared under the same circumstances. It's also important to note that the first day of sensor use is often worse than subsequent days, and you can see this borne out here with significantly higher MARD levels on the first day for both of these devices. The 20% error zone is not a particularly bad area to be in, but the Dexcom G6 in this head-to-head study had lower results than in their reported pivotal trial data. And these sort of head-to-head studies can be done in particular circumstances and worth looking at. One other major important factor determining CGM use, of course, is availability, and cost plays a huge factor in that. In Australia, a subsidy was introduced for people under 21 years, for largely with type 1 diabetes, and we studied this group before and after that introduction of CGM. Both the parents and children had a high fear of hypoglycemia, which reduced on sensor use, resulting in a higher total daily insulin dose and a small fall in HbA1c in this short-term 3-month follow-up. But it took a lot of resources from the department, especially educator time in educating the families on how to properly interpret the data available. And if we're making generalizations, there are quite a few differences between established type 1 diabetes and early CF-related diabetes, because the former often present acutely unwell, or at least are aware that they could become so, such as with ketoacidosis. Whereas with CF, they've had a long medical history beforehand, and then they're picked up on screening, and perhaps the consequences of not being adherent to this particular therapy may be less appreciated. With type 1, they're often on higher dose intensive insulin therapy and lower doses in early CF diabetes, and so the effects may be less visible to them. And intensive glucose monitoring is the norm for type 1 diabetes, but often not so in our early CF-related diabetes patients, which is then hard to intensify once those habits have been established. But there are many potential uses in CF-related diabetes for CGM. It's likely to be much more sensitive in managing insulin therapy than just HbA1c alone, which will be lowered by hypoglycemia as well as by underlying CF. The retrospective data is invaluable in identifying patterns, allowing particular dose changes, and then use of the compare function on the software allows you to see if those changes actually improved results. And that visual ability seems to work very well with the families. They also like the real-time ability to see what's going on at particularly important moments like sport, fasting, exams, etc. And as long as they know what to do in those situations, it can be very helpful. In the future, as I said, it may be possible for people to be on closed loop pumps, but these are all still designed with type 1 diabetes in mind. There are some other difficulties. So here are two examples of people who have put in false calibrations. This boy here put in a false reading at night and was slowly going into diabetic ketoacidosis through this period, but his mum thought everything was going well, looking at CGM values that were perfectly in range. When eventually the abdominal pain, nausea and vomiting got them to go to hospital, he was noted to be in DKA. And this person, also a teenager, was putting in numerous false calibrations, resulting in a much lower estimated CGM-based HbA1c than true HbA1c. Paracetamol can interfere with some CGM systems, resulting in false highs, and lying on your sensor, particularly at night, causing compression, can result in false lows. So it's important to do finger prick testing in both those situations. There are some barriers to hypoglycemia detection. So CGM systems are essentially designed mostly to focus on hyperglycemia. There's the lag we spoke about, and there's fatigue on the part of the patient or family to alarms, and particularly if there have been a lot of false lows. Recent modulator therapy, particularly with ivacaftor, looked very promising, but combined therapies perhaps may not be as productive of glycemic improvements. This 3-subject pilot study looked at the bionic pancreas by Damiano and colleagues, introduced to adults with established CF-related diabetes. 1 and 3 were on multiple daily injections and 2 was on a pump. And you can see here their mean continuous glucose monitoring results improved, initially here on insulin only, and then here on both insulin and glucagon. And this is interesting because the whole system is designed for type 1 diabetes and shows promise potentially for future use in CF. Another potential future role, of course, is early detection of elevated glucose levels prior to the onset of diabetes as currently defined. And that's been studied by Brucker and colleagues who looked at 142 children with the glucose, various glucose tolerance categories, and defined people according to their CGM parameters rather than OGTTs, which they said were not routinely performed. And those with high percentage time above 7.8 or frequent excursions above 11.1 were studied for their effects on lung function and so on. as well as looking at the interquartile range of glucose. Using these methods, they didn't find significant relationships between lung and nutritional status. Christine Chan and colleagues looked at 88 children with CF, 10 to 18 years, and also compared them to 22 controls, and did find strong correlations between elevated glucose levels on CGM and FEV1 and rate of change of FEV1. And Frost and colleagues looked at 59 adults with CF, looking at their percentage time above 7.8, and found that those with higher percentage time above 7.8 had poorer lung function and nutritional status. And interestingly, 37 of those patients went on to treatment and had improved for weight and lung function at 3-month follow-up. In our group, we've been looking at progressively younger children, and in this very young group of 5 to 9-year-olds, we've recently found that those who had greater than 4.5% time above 7.8 on continuous glucose monitoring had poorer mean annual FEV1 over the subsequent year than those in a better CGM category. So all of this shows great promise for further research and potential areas of intervention. The CF IDEA trial continues in these Australian centres and has been recently included Colorado Children's Hospital in Denver. I'd like to thank all of the children, families and colleagues at the centres, in particular the 3 colleagues mentioned on the screen. Thank you.
Hi, my name is Melissa Putman. I am an adult and pediatric endocrinologist. I see patients at the Boston Children's Hospital CF Center and also at the Massachusetts General Hospital Adult CF Program. And I perform clinical research focused primarily on CF-related endocrine disorders, including diabetes and bone health. And today I'll be talking about diabetes technology for the management of CFRD. By way of disclosures, I've served as a consultant for proteostasis therapeutics, and one of my research studies was funded by a Vertex investigator-initiated studies grant. So over the next 20 minutes, what I'd like to do is talk about the emerging role of diabetes technology in the management of CFRD, focusing mostly on continuous glucose monitors, smart pens, insulin pumps, and sensor-augmented pumps and hybrid closed-loop devices. And then we'll talk more about future directions in clinical research in this field, specifically on artificial pancreas devices. So most diabetes technologies were developed primarily for the management of patients with type 1 diabetes, and now moving on also to include type 2 diabetes. These devices were designed to provide more comprehensive glucose data for both patients and providers, and to enhance approaches to administering insulin, ultimately attempting to make diabetes control better and diabetes management easier for our patients. And I think in many ways, these technologies may be particularly useful for addressing some of the unique challenges our patients with CFRD face. And these challenges are, number one, patients with CF already carry a significant medical burden in managing their pulmonary disease and other aspects of CF care. And so when we add diabetes management, finger stick checks, insulin injections, all of these things to their care, it can be overwhelming and just lead to significant treatment burden. In addition, our patients often require high calorie, high carbohydrate dietary intake in order to meet their nutritional needs and keep their BMI in a good range. But these foods can lead to significant postprandial hyperglycemia that can be difficult to manage with insulin. In addition, Our patients often have fluctuations in insulin requirements depending on their clinical status. So when patients are well and feeling healthy, they may need less insulin. When they're sick or need to go on steroids, then they may need a lot more. And it can be difficult to manage blood sugar levels when your insulin needs are constantly changing. And then lastly, our patients, even those without diabetes, can have frequent hypoglycemia. And it can be really challenging to treat a patient with insulin who's already having frequent hypoglycemia. And these are the challenges that we hope we can help address with diabetes technology. So to start, I'd like to talk about some of the advances in glucose monitoring, specifically continuous glucose monitors, or CGM. So these systems are comprised of a sensor that has a tiny little filament that goes underneath the skin, and it senses interstitial glucose levels every 5 to 15 minutes, and then sends this information to a receiver or to the patient's smartphone. These devices have been shown to improve glycemic control and improve quality of life in children and adults with type 1 diabetes. What you see here are two of the currently available CGM systems in the US. The ones that we use the most are the Dexcom G6 here on the left, and the Freestyle Libre, which was recently a new version, the Libre 2, which is recently FDA approved. And both of these devices are FDA approved for non-adjunctive use, which basically means that CGM readings can be used in place of fingerstick glucose levels for decisions about insulin dosing. And this really minimizes the number of fingerstick checks that a patient has to do. In addition, these sensors are easy to place. They require replacement every 10 to 14 days. And neither of these devices require any fingerstick calibrations at all for use. But most importantly, CGM provides comprehensive real-time glucose data that just isn't captured by fingerstick glucose levels. And so not only does it make it easier to check blood sugar just by looking at a smartphone, but these CGM devices will tell patients, well, what direction is the blood sugar going? Is it going up? Is it going down? Is it staying the same? And then the devices will send alerts if the glucose is too high or too low. And this is an example here of some of just the comprehensive data that we get from a CGM device. And so this shows the average blood sugar over 14 days together over the course of midnight to midnight on a single report. It gives us the median blood sugar, which, as you can see here for this patient, is well controlled in the middle of the target range with an average blood sugar of 111 over the course of the day. Now, if we look a little bit closer and look at the daily view, where each color on this graph represents a different day, what we can see is that this patient is having significant postprandial excursions to the 250 to 300 range with almost every meal, but these excursions are only lasting about 2 to 3 hours. And so if we are only checking blood sugars before each meal, really we'll be missing a lot of the hyperglycemia that this patient is having. And so this is just a really good example, I think, of how helpful CGM can be in managing our patients' blood sugars. So there have been multiple studies that have validated CGM for use in patients with CF. Another study showed that CGM-guided insulin initiation was associated with significant improvement in pulmonary function and in weight. And as part of this meeting, if you go to ePoster 123, you'll actually see some really interesting data from a community voice survey. Now, this survey looked at 120 adults with CF and parents of children with CF and asked them about their attitudes regarding diabetes technology, including CGM and pump use. And overall, the attitudes about CGM were very favorable. So 76% of patients felt that using a CGM would help them take better care of their diabetes, and 86% felt that CGM makes taking care of diabetes easier. And this is actually consistent with my clinical experience caring for a lot of patients with CFRD, where I would say that most of my patients find CGM helpful, especially the high and the low alerts, and that overall CGM can just make glucose monitoring less burdensome. So I'd like to move on now to talk about advances in insulin administration. So this is an example of a smart pen. There's only one smart pen that's currently available called the InPen. And what this is the pen is linked to an app on the patient's smartphone. And the app will assist with bolus calculations. It will record all the boluses that the patient delivers using the pen. It will track insulin on board, which basically will tell the patient, well, how much insulin is still acting in their body after the dose was given. And also the pen can provide a very comprehensive report of blood sugar levels, of insulin administration, and it's very helpful to review with patients as we try to decide how to improve a patient's diabetes care. There are no published data of smart pens in CF, but I will say that many of my patients have actually found the smart pen to be very helpful as they manage their diabetes. And these are examples of insulin pumps. So a pump is a device that basically will deliver insulin continuously via a very small catheter that's placed underneath the skin. And all pumps basically operate with similar methods where it is giving a small amount of insulin all the time, and that provides the basal coverage for each patient. And then the pump will administer boluses. So when the patient eats carbohydrates or has high blood sugar or needs a correction dose, then the patient can tell the pump to give a bolus of more insulin. And pumps are really helpful. They allow us to fine-tune insulin delivery for each patient. We can change the basal rates like we need to. We can change boluses so that they match the different types of food intake. And they also can just make insulin administration a little bit more efficient and more convenient for patients. And these pictures are currently available pumps that we use. The Omnipod is very popular amongst my CFRD patients because this is the only tubeless version where the patient wears this pod, but there's no tubing that connects it to the controller device. This is the T-Slim and Medtronic versions that we'll talk a little bit about more in a minute. There are very few studies looking at insulin pumps in patients with CFRD. There was one study that reported improvement in glycemic control, weight, lean mass, and A1C in 9 patients with CFRD who were started on an insulin pump. But other than that, there's really not a lot of studies. I will say overall, insulin pumps are not as popular or used as often in patients with CFRD as they tend to be in those with type 1 diabetes. And interestingly, in this recent Community Voice survey, which you can see in e-poster 123, pumps were actually not viewed as favorably as CGMs amongst these people with CF or parents of children with CF. Pumps were seen as having fewer benefits and greater burdens. And this may explain why we see lower rates of insulin pump use in our patients with CFRD. The most recent versions of insulin pumps that are currently FDA approved, the T-Slim X2 and the Medtronic 670G and 770G, these pumps have the added benefit of being integrated with the CGMs. And so the pump can actually use information coming from the CGM to change insulin delivery. So there are the threshold or predictive suspend devices, which includes the T-Slim X2 with basal IQ software or the Medtronic 530 or 630G. The way that this works is the pump will use the CGM data to stop insulin delivery if the blood sugar is going below a certain threshold, or if the pump predicts that it will drop low. And so this is really helpful for preventing hypoglycemia. Now, there are the hybrid closed loop systems that are currently FDA approved are the t:slim X2 with Control IQ software. So the same pump, but with a different software, or the Medtronic 670G, and then most recently the 770G, which was just FDA approved earlier this month. These hybrid closed loop systems will actually adjust the basal rate and adjust insulin delivery based on how high or low the blood sugars are, so give increased insulin delivery or decreased insulin delivery as needed. And they can also give little correction boluses automatically when the blood sugars go high. In all of these currently available FDA-approved systems, the patients still have to make all treatment decisions, and they still have to manually bolus for carbohydrate intake and for correction doses. In addition, the Medtronic systems require fingerstick calibrations at least 2 to 4 times per day. So with all of these systems, there is still a fair amount of input needed by users to keep glucose in the target range. But I will say, these pumps, they're just getting better and better. And I wanted to show an example for you of a hybrid closed loop system in a patient with CFRD. Right now, there's actually no published data of these devices in patients with CFRD, but this was a patient that I saw actually last month, and he was having a hard time. He was using the Dexcom G6, but having a hard time managing his diabetes. And this report on the left is an example of a Dexcom, 2 weeks of Dexcom data prior to switching to the t:slim Control IQ. So he was using just regular insulin injections. And you can see that the average blood sugar was 196, a lot of time in the orange and yellow here, above range. He was only 46% of the time in our target range for managing his diabetes. And then we switched from injections to the t:slim X2 with Control IQ, so the hybrid closed loop system. And then this is what his report looks like after. So as you can see, his target blood sugar now is really within range almost all day. And now he's 82% time in range, and his average blood sugar was 135, which corresponds with an A1C of 6.5%. So now, I will say it wasn't just the pump that led to these improvements. It took a lot of work on the patient's part and motivation to get his blood sugar in good control. But I think that this case illustrates how helpful these devices can be in helping patients manage their diabetes. I'd like to talk a little bit now about future directions in this field, focusing on closed-loop artificial pancreas technology. Because ultimately, where this field is moving towards is, and what the goal is a device that requires minimal input from users to control blood glucose levels as automatically as possible, using either insulin alone or using a bihormonal device, which includes insulin plus glucagon. And there are multiple devices that are currently under development. And today I want to talk with you about the device that we're studying at MGH. And this is the bionic pancreas. So the bionic pancreas is a fully automated closed loop artificial pancreas device. So it's an insulin pump that's integrated with the Dexcom G6 CGM. And the pump will automatically adjust insulin delivery with or without glucagon to control blood sugars with minimal user input. It uses machine learning to continuously adapt online to the specific needs of each user. And I think this is really important for patients with CF whose insulin needs are often changing. So basically the device will learn what the patient needs and change that, that requirement over time. In addition, another big benefit of this device is that carbohydrate counting is not required. So patients can tell the device, oh, having a typical meal or a less than typical meal, but they don't have to. And actually in our pilot data, looking at CFRD patients, very few patients did any meal announcements, and we still got really good glycemic control. Right now, the bionic pancreas is currently being studied in a multi-center phase 3 pivotal trial in children and adults with type 1 diabetes. And this is an example of the bionic pancreas in adults with type 1 diabetes. And what I'm showing you here are average blood sugar levels for adults with type 1 diabetes doing their usual care in the white. These lines are the average blood sugar, and the circles are how much hypoglycemia they're having, with bigger circles meaning more hypoglycemia. And what we can see is that when these adults use the insulin-only bionic pancreas, they had improvement in their average blood sugars and hypoglycemia, with further improvement with the bihormonal device right here. And we did a pilot study in 3 subjects with CFRD. And these data look very similar to what I just showed you in type 1 diabetes, just with much less patients. We saw improvement from usual care to the insulin-only bionic pancreas in average blood sugar right here, with further improvement in average blood sugars with the bihormonal device. And what this slide doesn't capture is that at the end of this study, these patients didn't want to give the device back. It just made diabetes management easier. And that's what we're shooting for. So our next steps, we are currently enrolling for a short-term trial testing the insulin-only bionic pancreas compared to usual care in Boston, funded by the NIH. And then when this study is done, we will be doing a larger, longer randomized clinical trial with this device over a 6-month period in patients with CFRD. And not only will this study give us the opportunity to test the safety and efficacy of this device in patients with CFRD, but this is also going to give us a really unique opportunity to investigate, well, what is the impact of really good glycemic control on other outcomes in CF, on BMI, on body composition, on pulmonary function, on microbiome. So this really, I'm very excited to see what this study will show. I'm also excited that we are currently working with the CF Foundation through the Clinical Research Award Plus Planning Grant mechanism to expand this study to multiple centers across the country. So hopefully you may see the bionic pancreas in a center near you. So to summarize, I hope I've convinced you that diabetes technology offers the potential to improve glycemic control in our patients with CFRD, and most importantly, to reduce some of the burden of diabetes management that our patients face. And future studies are needed to better understand how this technology will impact our patients, and then also to test the safety and efficacy of new devices and new fully automated closed-loop devices in this patient population. So thank you so much for the opportunity to speak at this symposium, and I really appreciate your attention.
Hi, this is Trang Lee with Virginia Commonwealth University in Richmond, Virginia, where I am an adult and pediatric endocrinologist. And I also attend both adult and pediatric cystic fibrosis clinics at our CF centers here. I'd like to thank the presenters for the opportunity to discuss CFTR modulators and cystic fibrosis related diabetes today. I have no relevant relationships to disclose. Regarding an overview of what I'd like to cover today, I think it would be timely to review the literature regarding impact of CFTR modulator treatment on CFRD, originating with the case reports after initial introduction of ivacaftor, review pilot studies that are available, and ongoing analysis of registry data, so that from these we can glean potential mechanisms for improvement in glycemia if possible. Regarding CFTR mutations, at this point, over 1,800 mutations have been described in the CFTR gene, with wide-ranging effects on CFTR synthesis and function. And these were historically categorized on the left panel with the goal of grouping CF individuals with similar prognosis together in this 5-class mutation scheme, which is helpful for understanding impact of mutations on biosynthesis and function of CFTR protein. But in the era of CFT modulator therapy, looking at the panel on the right, this may be helpful to also think of the complexity of grouping mutations into distinct classes, because some mutations can lead to more than one effect on CFTR function. So this leads to the concept of theratyping, referring to classification of mutations by their responses to specific CFTR modulators. So ivacaftor was introduced for G551D in 2012 for a small proportion, about 4% of the entire CF population, quickly followed by lumacaftor or tezacaftor combination therapy, which is a corrector and potentiator combinations, and then followed by triple therapy introduction in October of 2019. These all have shown significant benefits across multiple clinical outcomes, including improved FEV1, improved pulmonary exacerbation rates, and improved quality of life. So now that it's been 8 years after introduction of ivacaftor, what do we know about both short and long-term impacts on comorbidities of CF with modulator therapy? So I wanted to review some case reports just to give a flavor of how interest in this topic had gotten started. A 25-year-old gentleman, Delta F508, G551D genotype, with 6-year history of CFRD on insulin, glargine once daily. After 13 months of treatment with ivacaftor, was able to stop the insulin and remain off for an additional year. Another patient, a 34-year-old gentleman with G551D mutation and CFRD for 8 years, treated with insulin for 7 of those, was able to discontinue ivacaftor after 6 months and remain at goal A1C for over 3 years before needing to resume insulin. In a case series of 8 Israeli patients with a gating mutation, after 1 year of ivacaftor treatment, 2 of 4 subjects reverted from CFRD to impaired glucose tolerance, and 3 with impaired glucose tolerance reverted to normal. None had a significant change in A1C, and a 31-year-old female with a CFTR premature contraction mutation was able to reduce her daily insulin dose by half at 3 years after ivacaftor initiation. So all very interesting case reports, and I think also important to keep in mind that there are some patients who will also spontaneously revert back and forth between different states of dysglycemia. So important to look at further studies as well. In a open label pilot study of just 4 weeks of ivacaftor treatment, one of the initial studies performed in 2013, enrolled 5 subjects with a wide age range from 6 to 52 years, and also a wide range in glycemia from normal glucose tolerance to long-standing CFRD on insulin pump treatment. Inclusion criteria were standard diagnosis of CF and G551D mutation and meeting age criteria. Prior to drug initiation, IV and oral glucose tolerance testing were performed on successive days, and these were repeated in the same order approximately 4 weeks after daily oral treatment with ivacaftor. So results are shown here. Of the 5 subjects, the 2 with CFRD and 2 with normal glucose tolerance, 1 with impaired glucose tolerance. 4 of 5 subjects significantly improved their area under the curve insulin response in treatment with OGTT. The patient with longstanding CFRD did not have an improvement, but the range was an increase from 66 to 178% improvement in insulin secretion on oral glucose tolerance testing. Similarly, for the IV glucose tolerance testing in baseline versus treated subjects, that there is increase in the normal glucose tolerance and impaired glucose tolerance subjects, and actually also in the patient number 1 with longstanding CFRD had some increase in insulin secretion, but a variable response here noted in the patient with new onset CFRD who had not previously been treated with insulin. And this was some early suggestion that with CFTR modulator treatment, there would be some direct responsive increase in insulin secretion that could be seen even with short-term treatment. In a longer study, 4 months, 16 weeks of ivacaftor treatment in 2 siblings, glucose tolerance testing was recorded at baseline and then again at 16 weeks. The 2 top panels represent the gentleman with CF and impaired glucose tolerance, who was noted to have actually some hypoglycemia after the initial glucose tolerance test when insulin levels were measured. When comparing the red baseline results to the 16-week post-treatment results, he did have higher insulin levels during the first 30 minutes corresponding to first phase insulin secretion, and had lower insulin levels for the duration of the 2-hour testing, highlighting the importance of initial first phase insulin secretion in maintaining euglycemia after a bolus of glucose. The sibling who had CFRD with a 2-hour glucose value of 214 actually improved after 16 weeks to 106, so more than normal glucose tolerance range, with persistent abnormalities at 1 hour and improvement in insulin secretion from the 30 to 90-minute time points. So more evidence of improvements in insulin secretion. And then moving on to, the circle here is to highlight the hypoglycemia that can occur at the end of glucose tolerance testing. One of the largest and most detailed clinical studies conducted regarding modulator treatment in CFRD so far, conducted by Kelly and colleagues, who assessed 12 patients with an age range of 6 to 42 years. 11 of these patients were 19 or younger, who underwent detailed characterization of insulin and incretin secretion by oral glucose and mixed meal tolerance tests, and by glucose potentiated arginine testing, in which arginine injections are used to stimulate first phase alpha and beta cell secretion at fasting glucose and clamped elevated glucose concentrations, thereby giving the ability to measure the acute insulin response and acute glucagon responses to IV arginine. This then allows for estimations of alpha and beta cell capacity, beta cell glucose sensitivity, and glucose potentiation of insulin secretion and glucose inhibition of glucagon, essentially attempting to quantify the interactions between alpha and beta cells. Overall, during the 4-month term of the study, there was no change in A1C. With regards to oral glucose tolerance testing, although fasting glucose was not different between baseline and follow-up, there was a subject with early 1-hour glucose intolerance that had normalized. With regards to mixed meal tolerance testing, there was no change in fasting or maximum glucose, no change in insulin or C-peptide, free fatty acids did not change, and there was no measurable change in incretin response. But there was an increase in C-peptide response during that first 30 minutes. With regards to glucose potentiated arginine testing, there were 2 interesting figures that I wanted to pull out from the paper here. So on the left panel, you can see acute C-peptide responses to arginine during fasting conditions on the left and during hyperglycemic clamp conditions on the right. So baseline is on the left side of the graph for both, and then responses at 4 months post-ivacaftor treatment are on the right. So looking at the dotted lines is pancreatic sufficient individuals, and the pancreatic insufficient individuals are represented in the solid blue lines. Under the fasting conditions on the left, for insulin, which is not shown here, but in a table if you'd like to refer to the original manuscript, and C-peptide responses under fasting conditions, both the insulin and here the C-peptide response increased significantly. Under hyperglycemic conditions, C-peptide response to arginine was significantly greater overall from baseline to 4 months of ivacaftor treatment. And this is a difference that persisted with adjustment for pre-stimulus glucose age and pancreatic sufficiency status. On the right panel shows data points from pre-ivacaftor and post-ivacaftor in red, along with their blue pre-treatment lines and red pretreatment fitted line, indicating the relationship between inhibition of glucagon and the acute C-peptide response under hyperglycemic clamp conditions. So pre-treatment, you can see the increasing C-peptide secretion in the context of hyperglycemia with increased glucagon secretion concurrently, so increased C-peptide and increased glucagon during hyperglycemia. That is, the slope of this line is actually dampened at 4 months of treatment, the relationship between C-peptide and acute glucose response. So this actually raises the possibility of glucagon secreting alpha cells potentially becoming more responsive to some of the inhibitory paracrine effects of insulin, suggesting potential for improved crosstalk between alpha and beta cells within the islet. So overall results of GPA testing, no difference in the fasting islet cell hormone concentrations, but there was some suggestion of improvement in C-peptide responses along with disposition index. There was some demonstrated improved suppression of glucagon in hyperglycemic conditions, suggesting some improvement in alpha-beta cell interactions within the islet. Regarding UK and US registry data, which is becoming increasingly available, that annual analyses are conducted of ivacaftor treated patients versus untreated matched comparators, assessing for risks of death, transplantation, and hospitalization and pulmonary exacerbations, and the prevalence of CF-related complications such as CFRD. So the ivacaftor cohorts included all patients with at least one record of having received ivacaftor treatment in 2014, sometime during 2014 or before. And those patients were matched with by age, sex, and severity of CFTR genotype in 1:5 ratio with ivacaftor naive patients to form the comparator. So initial analysis was done at 2 years in the UK registry and 3 years in the US registry, indicating that for the US registry patients, already during that time frame, those who were treated with ivacaftor had a lower prevalence of CFRD than the comparator arm for CFRD, which is a result that was mirrored in the UK registry data, 20.7% ivacaftor versus 29% in the comparator arm. And as more data has become available, with 5 years of follow-up, then we see further details of subjects between baseline at 2011 and year 5 at 2016, indicating that the increase in CFRD patients went from 23.6% to 35.7%. Versus an 18.3% increase in the comparator arm, so a lower increase in the number of percentage of patients with CFRD in ivacaftor treated versus the comparator group. Again, this was mirrored in the UK registry cohort as well. And of note, this looks just visually as a very significant flattening of the increase in percentage of patients with CFRD during this 4-year time frame. I did want to briefly mention some of the studies that are available on lumacaftor and ivacaftor treatment in patients with CF and CFRD or other abnormal glucose parameters. So in this very small trial of 5 subjects, similar to what we saw earlier reported for the ivacaftor patients, these subjects had IV and oral glucose tolerance tests at baseline, which were repeated at 6 to 8 weeks after initiation of treatment. Here, the results seem to be a bit more variable. So you can see that one subject with impaired glucose tolerance had actually progressed to CFRD, and one subject had reverted to normal glucose tolerance, and otherwise the results were overall more variable in this case. looking at a larger study of 40 subjects aged 12 to 61 years with a full year of treatment instead of just 6 to 8 weeks, who were previously lumacaftor, ivacaftor treatment naive. These were all subjects that enrolled for abnormal oral glucose tolerance testing at initiation of the study, whether it was just abnormal glucose tolerance or newly diagnosed diabetes on OGTT. Of those 40, 31 subjects at baseline had impaired glucose tolerance classification. None of the subjects during that year progressed to CFRD. A little over half reverted to normal glucose tolerance, and approximately a little over a third maintained the same glycemic classification. Of the 9 subjects with CFRD, approximately half showed some improvements, and then 4 of the subjects remained with the diagnostic criteria being met for CFRD. So I did want to briefly mention the only study using continuous glucose monitoring that has been used in assessing impact of CFTR modulators. So, and keeping in mind that at the present time, continuous glucose monitoring is not yet approved as a diagnostic tool for diabetes, but definitely continuous glucose monitoring can be a really sensitive tool for detecting early glucose abnormalities, even in those with normal oral glucose tolerance testing. So in these 9 preteen and adolescent subjects who had already had a baseline continuous glucose monitor course at a median of 26 weeks prior to treatment, anywhere ranging from normal glucose tolerance to abnormal to one patient with CFRD based on OGTT results. These subjects then were treated with lumacaftor, ivacaftor for a median of about 7 months after starting treatment before being reassessed with the follow-up CGM. And no changes were noted in the oral glucose tolerance testing and also not actually in the CGM measures taken as a whole. But when analyzed by sex, there was some suggestion of the male subjects showing lower glycemic variability, meaning less excursion of glycemia on the post-treatment CGM. Overall, just to summarize this brief overview, there's some pilot studies and registry data now demonstrating overall improvement of glycemia and CFRD in conjunction with CFTR modulator treatment. There have been improvements in insulin secretion and some pretty good suggestion of increase in first phase insulin secretion. Some potential improvements in islet cell function, beta cells and alpha cells. There's a widening gap between the prevalence of CFRD in treated versus control comparator groups, and that CFTR modulators could potentially contribute to amelioration of dysglycemia in CF, whether that be delayed onset of CFRD or some temporary reversal of impaired glucose handling or some temporary reversal of temporary decrease in insulin requirements. And all that with the caveat of this figure continuing to drastically change over the next few years as hopefully more patients are able to be initiated on CFTR modulator therapy, and hopefully as new agents continue to come out. In summary, I think there is some interesting data already kind of available with the amount of long-term follow-up that we've had, and longer-term follow-up will reveal more. I would like to express my appreciation to the CF Envision program, of whom I was in the initial cohort, and my colleagues at Virginia Commonwealth University, and thank you for your attention.